Hi guys, my name's Matt, I'm an F2 and today I'm going to be teaching about CT scans for malignancy. So, because malignancy is a very broad term, I'll be approaching this by using a case study to demonstrate when and why CT is used for malignancies. I'll then give you a bit of a challenging question where you can have a go assessing a CT yourself and coming up with a diagnosis, and then we'll quickly summarise everything at the end. So, straight into it with the case study. So, this is a 56-year-old man who presents to you in GP with right-sided abdominal pain, which started a few months ago and has been gradually getting worse since then. He also reports about 1 stone of unintentional weight loss over that time, as well as some intermittent frank hematuria, but no other lower urinary tract symptoms. And he's also reporting that he's been quite constipated over this time, opening his bowels maybe once every 4 or 5 days. On examination, you have a feel of his tummy and it feels soft, but you feel like you can potentially feel a mass on the right side of his abdomen, and you get a urine dip, and it's positive for blood, leukocytes and protein, but negative for nitrites, so you're not convinced about a urine infection. On the bloods, he has a high calcium, his CRP is a bit raised, and his renal function is slightly off baseline. So, as a GP, you're concerned about malignancy given his symptoms, so you refer him to the specialist under the 2-week wait, and in the meantime, he gets a CT. So first of all, I'm going to scroll from the anterior abdomen to the posterior abdomen, and I want you to have a look and see if you can spot the abnormality. Okay. Okay, so now I'll talk through it and I'll point things out as we go through. So we'll start off at the anterior abdomen again, and we can see the bowel loops here at the front, and as we work our way backwards, we can see the right kidney start to come into view here, and then the aorta, which does some contrast in, the IVC here, we've got the liver up here, and the stomach that just comes into view there. Okay, so we'll keep on going back. We've got the left kidney on this side here. Keep on going back. And we've got the vertebrae that come into view towards the ends. Okay, so the major abnormality here is this mass growing out of the right kidney. It doesn't look like a simple renal cyst because it's large, it's quite heterogeneous, and also it's enhancing. Simple cysts don't enhance as they don't have a blood supply, a little bit like this little circle here. There are lots of differentials for renal masses, but unfortunately I won't have time to go through this today, so I'll put a link to a useful website at the end for if you're interested. However, I can tell you this is suspicious for renal cell carcinoma. So this gentleman was then seen in the urology 2-week wait clinic. His case was reviewed and he was booked in for a CT chest to complete the staging of the RCC and check for metastases. The plan was then for referral onto the urology cancer MDT to decide on subsequent treatment. The CT chest is quite important because 25% of the patients with renal cell carcinomas have metastases at presentation, and common sites for these metastases are lungs, liver, lymph nodes and bones. And the staging itself is very important because it has a big impact on prognosis. So stage 1 renal cell carcinoma, i.e. small, non-metastatic, non-invasive, has a 90% 5-year survival rate, and that's compared to stage 4, which is invasive metastatic cancer, which only has a 5% 5-year survival rate. So this is the staging CT chest, which we can see as we scroll down from the apex of the lungs down to the bases. We can see multiple nodules on both lungs throughout both lungs, which in this context most likely represents secondary metastases from the renal cell carcinoma. Okay, so reviewing this case, we had a patient who presented with features very suggestive of malignancy, i.e. unexplained weight loss, which should be a red flag in any situation, frank hematuria, except in the context of a UTI, and raised calcium, which was causing the constipation in this situation. With a raised calcium, you should always suspect bony metastases, or in this case, paraneoplastic syndrome, which is actually quite common in renal cell carcinoma. Things to note with regard to the CT scanning for RCCs. One, most renal cell carcinomas are actually picked up incidentally these days. It's less and less common to have the classic triad of flank mass, hematuria and flank pain. And two, CT is probably the most useful tool for diagnosing and staging RCCs, but it's less useful in other types of cancer such as prostate cancer, where imaging like MRI might be more useful. Every cancer is different and complex in its own way, which is why we need to bring experts in each field together into cancer MDTs. Okay, so now we'll finish with an SBA question. I'm not going to give you too much information because I want you to have a look at the scan and pick up on the clues in the images that will point you towards the most likely answer. Okay, so a 35-year-old female presents with worsening lower back and bilateral hip pain. What's the most likely cause? Is it A, discitis, B, pot disease, C, herniated disc, or D, breast cancer with bony metastasis? Okay, so as before, I'll scroll through slowly first, and I want you to pause and have a think, and then I'll take you through the scan again. Okay, so we're going from the top of the body down. Okay, so we'll come back up to the top again and I'll talk you through it. So I've noted from the history that there's back and pelvic pain, so that's where I'm looking closely first of all, and I can see multiple, what look like multiple lytic bony lesions throughout a lot of the vertebra, and then also as we come down into the pelvis we can see these lytic lesions on the pelvis bilaterally also. So this immediately makes me think of two things: multiple myeloma or bony metastasis. From doing a full review of the rest of the CT, I know that this lady has had a left mastectomy. So we come up here, so you can see the right breast here, but no left breast. And this is most likely because of a previous breast cancer. And this makes sense because one of the more common causes of bony metastasis is breast cancer. Therefore, putting two and two together, this young lady has likely had recently treated breast cancer, which unfortunately has already metastasized to the bone. Discitis and herniated discs are usually more discrete lesions and are actually better imaged with MRI. Pot disease is TB that's spread to the spine. Again, tends not to be quite as diffuse as this. Plus there's a lack of significant TB changes on the lungs, and MRI would be better for imaging pot disease as well. So to summarise, cancers can present in many different ways. The most important thing to remember as a junior doctor is you need to know when to suspect cancer and flag it up to a senior. For this, there are nice guidelines that I'll put a link to at the end if you're interested. It's also important to remember that a lot of the time it's the metastases that can present first and not the primary cancer. If you're interested in radiology and want to get better at reading CTs, the most important thing you can do is just to look through a lot of them. And remember, it's just as important to know what normal looks like as it is to know what abnormal looks like. Okay, well, thanks for watching. I hope you enjoyed the video. I've left links here for the nice guidelines and also to look up a bit more information about renal masses on CT scans. Thank you very much and please subscribe.